Question to Suri Prakash garu. What are the most critical early orthopedic decisions that influence survival and limb salvage in polytrauma?
When it comes to polytrauma, it all starts from the ER and then goes to OT. So it's like from a contaminated area, the patient comes to the ER and then it has to go to the OT. And it passes through series of minor decisions which are more critical. Actually, saying it is a time critical decisions that we take in the ER, which brings the survival to the greatest of the patient. So when you see a patient in ER, we need to prioritize the patient in three aspects: whether the patient is dying, or the limb is dying, or the function is lost. So if you see a patient, you need to think about life first, limb next, and then the function next. As per ATLS protocol, it is the hemorrhage that causes death of the patient. So you need to control the hemorrhage first. You need to decide where and all the hemorrhage is going on. So in orthopedics, what we commonly see is the pelvis is a major area where we see lots of hemorrhage that is happening. So usually the pelvis holds around 4 liters of blood, 4 to 5 liters of blood. So the moment you see a patient, you need to apply a pelvic binder and control that hemorrhage. And the next most common is the long bone fractures. You see a long bone fracture like your femur holds up to 1 to 2 liters. You need to splint the femur, make it immobile so as to stop the next consequences. And then next comes the patient is stable. You need to look for the limb, whether the limb is dying because of lack of vascularity or limb is dying because of lack of proper splinting. So if there is a vascular insult to the limb, you need to immediately address it first. You need to check it first. As a part of early decision, you need to check whether the pulse is present or not. If the pulse is not present, you need to go for a Doppler scan to see whether it is perfusion is happening or not. And even if ankle brachial index is less than 0.9, you need to go for the further imaging with a CT scan. These are the critical decisions. And one more is if it is an open fracture in the ER setup, first and foremost thing is like immediate administration of antibiotics is crucial. So, and tetanus, TT injection has to be administered immediately. It's always early stabilization of the fracture is important, then delaying it.
My question to Kalyani, madam. You are the first person to see a case in the emergency room. What are the most common airway mistakes in emergency trauma care and how can they be avoided?
Most common airway mistakes is directly trying to intubate the patient immediately without pre-oxygenation or positioning the patient. This can be avoided by pre-oxygenating patient for 3 to 5 minutes and positioning patient and making suction and everything available and airway gap is available. And another is not anticipation of different areas. Different area. So, preparing no backup plans and all, especially facial trauma cases, cervical spine instability, and neck trauma, neck hematoma cases, facial burns. In these cases, we should always prepare for backup, and if needed, we should prepare for surgical endurance. And not anticipating aspiration. Most of the patients may come with full stomach. While implementing, we should apply suction available and we should apply tripod pressure and do rapid sequence selection and this passing as well as after integration. And not able to recognize esophageal intubations, delaying its transformation and we should. It can be avoided by collecting PCO2 waveform and 5-point oscillation. So, chest wise. There is cervical instability. We should avoid displacement by manual impulse stabilization and always arrange for a suction airway or percutaneous stability. if there is any do not ventilate or do not integrate condition.
Coming to the case is taken for surgery. What mindset and skill set distinguish a trauma anesthesiologist from routine anesthesia?
Person dealing with like a trauma, the anesthetist should be have a resuscitation mindset, and he should be adequately skilled in handling difficult airways, like especially trauma airway. It's very difficult at times of facial trauma as a part of multiple injuries. As a routine anesthetist, will be seeing resuscitation once in 100 or 200 cases. But as a trauma anesthetist, like every case is a resuscitation case. You're dealing with the case, giving anesthesia and resuscitation go hand in hand actually. And the anesthetist should be like do multiple things at a time, like airway, securing lines rapidly, sending blades and all that will go and hand in hand and not in a sequence.
It's not like A, B, C. It is
Yeah.
simultaneously A plus B plus. Thank you. Suryaprakash, sir, coming to damage control orthopedics versus early total care. How do you decide between temporary stabilization and definitive fixation in today's trauma settings?
Early total care is nothing but fixing definitively any fracture within 24 hours from the time of arrival. So there are very few indications for the early total care in a polytrauma patient. So the patient should be stable enough. There should not be any hypovolemia. There should not be hypothermia, and there should be any minor injuries in the body, like a chest injury or head injury. Minor injuries are okay, acceptable, but if it is with a like the contraindications are again head and spine injuries and the chest injuries. The basically it is like a physiologically stable patient can go for a early total care with a definitive fixation using a plate or a nail. Whereas when it comes to damage control orthopedics, it means that whenever a patient gets injured, it is called as first hit. So the injury itself is first hit. So you need to avoid second hit by doing a surgery. What happens in first hit is the inflammatory response in the body will be at peaks during the first 72 hours. It peaks up to 2 days and then goes up to 5 days. So whenever you have a polytrauma patient, they'll be having like hypovolemia, hypothermia, and coagulopathy. So this damage control orthopedics comes into play. So you avoid second hit by not doing surgery in damage control orthopedics in the first setting. So in every case, like you first stabilize the patient by applying a simple external fixators and give the time for him to recover before going for a major surgeries. So that is damage control orthopedics.
Kalyani, how critical is early massive transfusion protocol activation? What delays do you commonly see?
Early massive transfusion protocols is life savings. Goals of massive transfusion protocol is to rapidly resuscitate hemostatic resuscitation and preventing dilation of coagulopathy by minimizing excessive corticosteroid use and early reduction of fibrosion and optimizing oxygen delivery and balanced component therapy. Most common delays we see is first under recognition of hemorrhagic shock, lack of a person who is required for declaring activation of massive transfusion protocol, and blood bank logistics, transport delay, cross-match confusions, and person not available to go to blood bank and bring the blood components, and not giving the racemic acid early. It should be actually given within 1 hour, not after 3 hours. It is beneficial to give the racemic acid in hemorrhagic trauma.
Even recently, head injury also tranexamic acid is there. Kishore, so operating room readiness regarding What is a trauma-ready operation room, and how can hospitals realistically achieve it?
Trauma ready operating room is basically a response ready, not enriched with all gadgets and equipment which it should be basically response ready. The OT should be ready in 10 to 15 minutes, not more than that. For that, every team should be ready, and every person in the team should have definite roles, and they should be prepared, like trauma anesthesias, sites, surgical sites. Everything should be ready. Checklist should be available instead of searching for the things around and creating a chaos.
Okay. Next question also to you. How do stress, night duties, and cognitive overload affect trauma outcomes? Because you are one of the Marathon anesthesiologists, staying more than 12 hours.
Definitely, stress will and work overload will hamper the outcomes, whether it is trauma or elective, because your decision making will be affected. You will have a tubular vision. You will be looking, you're not looking, take the situation as a whole. You will be like tube vision. You will be tackling a single situation, whatever comes in your mind. Whenever a person feels stressed or when diagnosed, always take help because it is really the life of a person who's there in our.
Yeah. Surbhika, so regarding what are the non-negotiable timelines in open fractures and vascular compromised limbs?
Non-negotiable timelines, like for any trauma patient, there is a golden window. So as soon as you see a patient in ER, like first thing, foremost thing is like administering the antibiotics in an open fracture within 1 hour, and straight away tetanus prophylaxis, whether they have taken it before or not, is always a good sign. And stabilizing the patient first should be done as soon as you anticipate some bleeding in the pelvis, like applying a pelvic binder the minute you see them with a pelvic trauma. And when it comes to compartment syndrome, it's like within 6 hours, uh, it has to be fasciotomized. It is better to fasciotomize even before that. It's like it's not that like you need to wait for 6 hours, and because as you wait, muscle necrosis will happen, and then it will lead to Bachman's ischemic contracture and permanent disability. And if it is a vascular injury, it has to be revascularized within 6 hours, so as to improve the perfusion rates. Yeah. Yes.
Kalani, coming to permissive hypotension versus organ perfusion, where do we draw the line, especially in polytrauma with head injuries?
Permissive hypotension is life-saving and uncontrollable hemorrhage. Especially the goal is to prevent the discharge of clots until we control bleeding. But in case of polytrauma with traumatic brain injury, a single episode of hypotension is toxic and increases mortality, it doubles the mortality by worsening the outcome by decreasing the central perfusion pressure, which causes secondary brain injury.
Sure, sir. What are the most dangerous communication gaps between surgeon and anesthesiologist in trauma cases?
Not communicating directly. Maintaining a loop.
Many of the time there will be like a communication gap between the surgeons and anesthetists. A few examples, if I can tell, like the most dangerous communication gap is the information regime not stated, it's not delivered. The patient is like hypertension analysis may be asking the surgeon may be telling the bleeding is not much, actually. And the other way, like the patient is deteriorating, the anesthetic should also equally communicate with the surgeon to tell, like, if he can do something like clamping or packing to stop bleeding till the patient becomes hemodynamically stable and then proceed with the procedure. instead of communicating, if he's like try to do something, uh, it will be the outcomes will be not affected.
Suryaprakash sir, regarding orthopedic leadership in trauma teams, how can orthopedician take a leadership role without delaying other life-saving priorities?
More than a leadership, we need to work together. It has to be a teamwork where critical care physician is the one who is handling the patient in most critical situation. So we need to work alongside with them. When the ABC in a ATLS protocol is being done, we need to take care of the X just before ABC.
Yeah.
So exaggerating the hemorrhage. And we need to give them proper space and splinting the limbs instead of rushing and splinting the limbs and sending them to a side. And we need to always think physiology first rather than fixation. So fixation always comes second to the physiology. And whereas as a orthopedician, we need to communicate it. We need to take a lead in communicating with other specialties like a general surgeon, chest trauma specialist, and neurosurgeon. We need to explain them different aspects of that trauma patient and communicate with them for a better plan in the next stages. And as a orthopedician, we have little liberty in saying that which fracture has to be addressed first, which system has to be stabilized first when it comes to the sequence of surgeries that we do it.
Kalyani, on point of care tools, after there is so much of development, how have ABG, ultrasound, that is the focus, lactate, thromboelastography, how these tools change trauma outcomes?
Point of care tools, ABG is single most easily available tool for us. Through ABG, we can immediately assess acidosis, hypoxia, hypercapnia, and it can guide us in ventilation. We can know about the lactate levels, and we can know about the base deficits. It is a silent, it indicates silent shock. Lactate is a marker for tissue hypoperfusion, and it can help us in monitoring. Lactate trend will help us in monitoring the response to the resuscitation. And EFAS we can do easily in casualty itself, and we can easily identify hemoperitoneum, hemothorax, cardiac tamponade, even pneumothorax we can identify. And through this we can avoid unnecessary CTs, and we can reduce the time from ER to OR. We can shift it immediately, and if these tools are easily available. And thromboelastography is it identifies trauma-induced coagulopathy within minutes, and it identifies early fibrinogenesis, and through this we can avoid unnecessary blood transfusions, transfusion-related complications.
Even for tracheostomies also, you can use ultrasound in focus. Suryaprakash, last question for you. Common avoidable errors. In your experience, what orthopedic mistakes convert survivable injuries into poor outcomes?
Trying to be a hero when the physiology is not good, going and operating hours together is a common avoidable mistake. And waiting for the perfusion to happen when there is a vascular injury.
Okay.
So we need to. So missing a vascular injury is directly proportional to losing a limb.
Yes.
So I have to diagnose it first and then reperfuse the limb. And waiting for the compartment syndrome to settle down. So when in doubt, fasciotomy always saves the limb. So we should not wait for the compartment syndrome to settle down when the clinical signs are very pointing out for it. And open fractures, waiting for overnight, thinking that, okay, it's okay to wait is always a bad sign. So the moment you see an open fracture and when it is contaminated, straight away debride it. And communication with plastic surgeon is also very much important, because a well-fixed fracture without a soft tissue coverage is always a disaster.
And one more thing, generally in dislocations, the pulses will felt.
Yes.
Is it because of this dislocation or real vascular injury also?
So
Can
in
it happen?
dislocations, one thing, the dislocated limb can directly compress the vessels. And the other thing is like because of the trauma mechanism, there can be a vasoconstriction where you can't see the pulses in the initial stage, which can be later on when the perfusion can happen, you can feel it.
Kishore sir, training the next generation. What changes are needed in anesthesia training to produce competent trauma anesthesiologists?
I think in the curriculum, anyway, they'll be learning about the trauma and they'll be having the rotations in emergency OTs. And in trauma ICUs, they'll be trained as well. But the training can be reinforced with special training in difficult intubations, mapping-based or simulation-based training in case of such scenarios, life-threatening scenarios, which are rare to see, but they can be trained through simulation.
Yes.
And they should have good knowledge on trauma physiology, massive transmission protocols, and ATLS especially. On these aspects, I think anyone can handle trauma.
Do you think like cardiac anesthesia, neuro anesthesia specializations, trauma anesthesiology needs to be introduced in curriculum or?
Trauma, I think it can emerge in the future, but as of now, it can be as a routine training for every student, for every PG or for every MS.
Kalyan ma'am, last question for you. With this question, we end this session. ICU hand or failures we commonly encounter. What ICU practices convert good initial resuscitation into bad outcomes?
For example, if ER team comes to ICU, you hand over and the patient is stabilized, vital stable, and not clarifying about if it is the permanent control of damage or temporary control of damage, like ongoing bleeding, ongoing transfusion requirements, any open abdominal injuries, long bone injuries, pelvic stabilizations, like cervical spine stabilizations, if these are not being handled, this can lead to other meritorious actions and the chances of rebleed and coagulopathy. And not handling about proper resuscitation. Either the ICU may think that massive transfusion protocol can de-escalate and they can stop it early. And they can give over 3 years IV fluids and they will cause pulmonary edema and raise into abdominal pressure and not emphasizing about hypothermia maybe they can transmit lot of blood and not emphasizing about hypothermia which in turn worsens the coagulopathy. And not discussing about sedation especially in traumatic brain injuries, which may cause septic surge and cause secondary brain damage. And target BPs, not discussing about target BPs, especially in traumatic brain injuries, allowing hypotension, which causes secondary brain damage, and not discussing about ventilation strategies. If there is any lung confusions, lung protective ventilation settings should be kept, not discussing about all these things.
Thank you. Thank you for enlightening all of us with the latest things in trauma care.